This presentation is intended for the congressional body who enacted the Hospital Readmission Reduction Program. Our intention is to explain issues that have been identified supporting our opposition to the passing of this law. This program imposes a penalty on hospitals with readmissions within a 30-day time period. If this is the right change for healthcare reform, all hospitals need to be treated equally and adjustments need to be made for their diverse populations. One of the key questions is whether the Medicare 30-day readmission reimbursement model is cost-effective, beneficial, fair, and functional among all healthcare organizations. While this law is an opportunity to provide those things, a study done by Mittler and Partners found there is little evidence-based data to support any intervention that decreases hospital readmissions. Readmissions within 30 days may be due to patient noncompliance, inability to afford medications, or lack of transportation to follow-up care. In other words, factors outside of the hospital's control would become their liability. Hospitals with vulnerable populations have the potential for higher readmission rates. The additional financial penalties and reimbursement cuts due to healthcare reform can worsen care coordination and exacerbate health disparities in such communities. Hospital systems are closing facilities in these underserved communities because they are consistently losing money. The penalties will hurt these areas by removing health care altogether. When creating this law, Medicare took into account the sickness of the patients when calculating whether the readmission rates were higher than those of the average hospital, but not their racial or socioeconomic background. In order to provide high-quality, cost-effective care, these factors need to be addressed and adjustments need to be made. Barnes Jewish Hospital in St. Louis, one of the hospitals where high penalties will be imposed, has tried sending nurses to patients' home within a week of discharge to check up on them and schedule their follow-up care with a doctor or clinic, but half the patients never came to their scheduled appointments. For these reasons, the high readmission rates do not reflect the efforts and creative solutions in place. Almost $300 billion in avoidable medical spending is from medication noncompliance. This problem causes a third of hospital readmissions. Penalty for these readmissions does not fix the problem, but rather leaves the hospital struggling financially to provide interventions to decrease this problem. If the hospital readmission reduction program is the right choice, then it needs to be functional amongst all organizations. According to Bala and Colcutt, a hasty one-size-fits-all approach is unlikely to work in formulating details for the most important healthcare reform in a generation. The HRRP has the potential to be transformational, but it needs revision to its current application.